A very good morning, everyone. And at the outset, I would like to thanks to organizers for AMCO to 2025. And my special thank to Dr. Ashutosh for inviting me and giving this opportunity to talk on this platform. And he given me this responsibility that I have to talk on very practical aspects of a day-to-day practice and any clinical situation like a pneumonia. So I'm going to discuss a very practical case of pneumonia, what we did in this case, what we are doing in the day-to-day practice. So some of the things are good, some of the decisions may be wrong. And we have wonderful experts with me, Dr. Puneet, Dr. Ravi, Dr. Rakesh, and Dr. Sameem, and Dr. Ashish. So this is a true case which I'm going to talk about. So this was a 65-year-old male, diabetic hypertensive, a non-smoker. Total duration of illness is approximately 10 days, having the mild dry cough, fever, left-sided chest pain 1 day, and breathlessness for the last 2 days. Having progressive symptoms and fever, respiratory rate is 24, little bit hypertensive, the blood pressure is 90/50, and chest decreased breath sound on the left side, predominantly on the left side. The rest examination is within normal limit. Investigations, the TLC 3400, serum creatinine 1.8, and VUN is 44, and received oral antibiotics, augmentin and azithromycin. And this was the X-rays. So, you see, I just want to explain that I have not given any information to the experts. I have not given any question or answer to the experts. So this is everything new for them. So my first question is to our experts. What is your probable diagnosis? Any of the experts. It's a very simple practical case which we see in a day-to-day practice, and after seeing this clinical finding and this X-ray, what is our diagnosis? Ravi.
Thank you, sir, for wonderful question. First of all, I want to congratulate Dr. Ashutosh Gupta for this wonderfully organized conference. And a special word for my teacher who is here, Dr. Alok Chandra, sir. I owe much of my journey in chest medicine to your guidance, sir, even today also. Now, coming on to today's question, what is your diagnosis? As it's clear, we can see left-sided homogeneous opacity and bilateral chest breath sound is decreased on left side. So, provisionally, first of all, we will think of effusion only. There must be some fluid in left side of the chest.
Sir, my diagnosis is left-sided consolidation with effusion, with septicemia, with septic shock, with acute kidney injury.
So basically, we have a disease which is confined to the left side, that may be an effusion, maybe associated pneumonia, and there is some systemic inflammation because the creatinine is 1.8, but the count seems to be normal. So it's a simple pneumonia. It's coming to your OPD with these symptoms. Now, where you will manage the patient, whether you will write the antibiotic to these patients and send the patient to home, or you will admit this patient in the hospital, or you need to hospitalize this patient in intensive care unit. How to decide that this patient should be managed where?
So actually, sir, just the patient is 65 years of age with comorbid condition, and if you look at that, the raised respiratory rate and blood pressure is lower side, either systolic or diastolic, with some uremia and raised creatinine. So it's according to agar scoring, it looks like that patient should be admitted.
Should be admitted. So these are the common clinical findings with the patient present to our OPD, presented with fever, dry cough, chest pain, tachycardia, very common presentation. And just to remind this importance of this pneumonia, clinical presentation. Fever is absent in 40% cases. That is very important point, especially in immunocompromised patients, elderly patients, and in pediatric case. They are coming with the non-specific symptom. So fever is not a diagnostic of pneumonia. You have a pneumonia in 40% cases without fever. And systemic symptoms are dominant like anorexia, weakness, especially in elderly populations. And sometimes they just present with the hyponatremia. When you investigate, you find the patient is having pneumonia. And sometimes they are coming with the altered sensorium. So as the doctor said that this patient should be admitted, and how to decide, there are the few factors which we consider where the patient should be managed, whether we should write the antibiotic to the patient in OPD, should be admitted in hospital, or should be admitted in intensive care unit. This is curve 65, this score. We take the half of this score. This is simply a confusion, raised BUN, respiratory rate, blood pressure, and less than 90, and age is 65. If the patient is having only 1 point, then we should write the antibiotic and send the patient to home. If somebody is having 2 points, the patient should be hospitalized. If the points are more than 3, this patient should be hospitalized in ICU because he is going to deteriorate because the disease in the progressive form. And other criteria is pneumonia severity score, although it is very lengthy process, but is more accurate. In practical life, we are using only curve 65 for evaluation of the patient and where we should manage this patient, whether in OPD or should be hospitalized or should be admitted in ICU. So our patient is having blood pressure 90/60, BUN is 44. So this is having got 2 points. So the patient should be hospitalized. So patient is hospitalized in medical emergency ward. Resuscitation is started by IV fluid, NORAD by the 6 ml per hour, and relevant is investigation was sent that the patient is having little bit of hypotension. So what investigation you will prefer to evaluate this patient? You have admitted this patient in the ward, antibiotic started, and resuscitation started. What investigation we should send at that time? Yes, please.
Sir, first of all, we send the blood cultures and sputum examinations patient. If ultrasonography is available, you see the ultrasound guided. If is possible to tap the pleural, if is more amount and any.
Sir, I would like to send routine investigations like CBC, hemogram with differential counts, and LFT, KFT to check the organ dysfunction along with inflammatory markers. I would like to do CRP, procalcitonin levels,
Right.
to different procalcitonin to differentiate between bacterial and other etiology. And simultaneously, if the bedside ultrasonography is available, then I would like to rule out the synpneumonic effusion. If there is a
Absolutely.
fluid,
So
then
we have to send the routine investigation. We had to send some specific investigations like an PCT to find out whether the patient is a bacterial infection or viral infection, and do the ultrasound or CT scan just to rule out associated empyema. We did the same thing here. So what is the role of sputum culture in the gross appearance of the management of this patient? We usually ask the patient whether you have the dry cough or you are having some sputum production. What is the role of that point? Should we send the sputum for examination, or gross look of the sputum is significant?
Sir,
Not.
I would like to send the sputum for gram stain and AFB smear. Gram stain primarily look for the results would be available in minutes to an hour, and I would like to see if it is gram negative predominant or gram positive. And it would help me in deciding the course of antibiotic. The next part for sputum culture, I would not very much rely on the result of sputum culture because usually sputum phlegm gets contaminated from the upper respiratory tract, and it would not clearly reflect the pathology. It might miss the
Right.
pathological bug.
Absolutely. Because this sputum culture is not very important. Most of the time the patient is in the oral flora, so it's not giving that a true organism. But the color of the sputum is very, very important. If we ask the patient what type of color you are having, and most of the times we ask the patient to collect the sputum in the night, so that you can see in the morning round, and the color of the sputum can suggest to some extent what is the probable organism. Like in case of Klebsiella pneumoniae, the current jelly-like colors. It is sometimes we get confusion. The patient is having hemoptysis, but this is not hemoptysis. In case of the Streptococcus pneumoniae, which is the most common organism, color of the sputum is the rusty colors, and dark yellow color is greenish, is the Pseudomonas, and blackish is most of the time is fungus and it is tubercular. So just by seeing the color of the sputum, we can suspect the possibility that this may be the organism, and that will help in starting the antibiotics, although the culture of the sputum is not very specific. Yes, any comments? Yeah.
Beside culture, also the smell of sputum suggests whether if it's
Yes.
foul smelling, then I think it suggests some anaerobic infection is
Yes,
there.
yes, yes.
Lot
The
of
foul
people-
smelling is suggested
Yeah.
the patient is having a lung abscess. Probability is very high that we are dealing with the anaerobic infection. So our patient was not producing any sputum even after the steam inhalation, nebulization of saline and physiotherapy. And the demand of oxygen therapy is gradually increasing. And saturation was 90% at 6 liter per minute oxygen nasal cannula, which is a significant demand of oxygen. And we have to start antibacterial and other antibiotics in this patient. So what are the points to be considered? Because the patient has already received augmentin and azithromycin. So what antibiotics you will plan in this patient, because we don't have any other investigation at this time and your patient is deteriorating. So what are the points which you have to consider before planning the antibiotic in this patient? Yes, any expert?
Sir, I would carefully look again patient history. If patient has visited any healthcare setting or not in the last 3 months, if patient has frequent visits for any other reason, whatever the reason. Patient might have, this is not a community acquired, it might be hospital acquired infection where microbial flora would be absolutely different. Airway, frequent visitors to hospital gets colonized with hospital-based flora. So antimicrobials for community acquired pneumonia would not work in hospital acquired pneumonia. If that is not a case, then I would like to do a CT, and we need to rule out any mass lesion, any obstruction, any foreign body in the airway. And if that is not a case, I would like to go for fiber optic bronchoscopy
Right.
and do a PCR
So
panel.
at this point, because we don't have any investigations suggestive of what type of organism is this, and patient is deteriorating, we will not prefer the invasive investigation to these patients. So these are the few points which we have to consider when we start empirical antibiotics, where the patient had developed pneumonia, as the expert says, whether it is community acquired or hospital acquired, because the flora is different. In hospital, Pseudomonas, Klebsiella, Acinetobacter is important, and in community acquired, it is always, most of the time, the gram-positive infection, or it is some atypical, or it may be viral infection. And what is the probable organism? You've just taken a history and should look for the sputum and see the profile of the patient. And the age and the comorbidity of the patient, what is the immune status of the patient. Like an HIV patient, the probability of pneumocystis cerevisiae is very high in these patients. And what is the radiological pattern, whether it is lobar consolidation or it is diffuse involvement of both the lung. What are the systemic manifestation? What is the hemodynamical stability that will suggest the virulency of the organism? And what antibiotic the patient had received the last recent past 1 or 2 weeks. So these are the few points which we have to consider at that point, because we have to start antibiotics, and these are the basis when we select the antibiotic, in particular in this difficult situation. So we have started meropenem amplet doxycycline, suspecting it may be a gram-positive infection, and the patient is elderly and diabetic. So mixed infection possibility is there, and already received azithromycin as well as augmentin. So these are the reports of the lab reports. The TLC was 3,400. Again, this counts was not very high. And you see this creatinine again 1.6. There is a little bit of hyponatremia, PCTY 0.4. CRP 48, AVG revealed respiratory alkalosis with hypoxia. This is hyperventilating. The positive finding is hyponatremia, normal PCT, and little bit of hypoxia. How you interpret this data in respect to this patient, Dr. Ravi? We have this information with this clinical background, how you correlate and how you proceed further.
Actually, like this patient is hyponatremic, we don't know what is the sugar status, because whenever we see there is hyponatremia, we should always see the sugar status of patient. If there is much hyperglycemia, then we have to adjust the sodium on an average 2 millimole equivalent per 100 milligram of rise in RBS above 100. So we can't, without sugar, knowing the sugar status of patient, we can't be sure that this is true hyponatremia, number one. Number two, TLC is decreased. It looks like mostly viral etiology. In virals, basically, because polymorphs are not so. Can I know the exact, what is the neutrophil count? It's 7,000, more than 7,000. So we have to see the absolute neutrophil count also in this patient.
So the neutrophil count is,
and we can see
70%.
procalcitonin is highly small, means raised, so it goes towards bacterial infection, bacterial etiology, because normal procalcitonin is less than 0.25.
Right.
And
so by this information, this look like the patient is not having any bacterial infection. This seems to be something else.
Sir, it
Yes,
seems
Anik.
to be like Legionella pneumonia. Hyponatremia is one of the specific manifestations.
Absolutely. The important finding is hyponatremia, because some of the patient, they present with hyponatremia. So that I will discuss later, but that finding is very, very important. Normal PCT with hyponatremia. Normal PCT means we are not dealing with some bacterial infection. So implication of the PCT value is here. If the patient is having 0.5 to 2, it is suspected case of the bacterial infection. If it is less than 0.5, it is unlikely to be a bacterial pneumonia. If it is more than 2, it seems to be a bacterial infection. If it is more than 10, there seems to be the patient is going to develop the multi-organ failure because of the bacterial pneumonia. So PCT is very, very important. But again, it is very important to remember the PCT is not used alone. We have to combine the clinical situation and the clinical profile of the patient, because sometimes there are a lot of causes of raised PCT which are not because of the bacterial infection. In early stage and first 48 hours PCT may be normal, especially in case of the pseudomonas. So it is not giving the true value, but definitely the supportive evidence, normal PCT in a patient who is having hypertension, raised creatinine, it is unlikely to be a bacterial pneumonia. So what are the common causes of pathogen associated with the pneumonia, like in this situation? The one is bacterial pneumonia, it may be viral pneumonia, it may be atypical pneumonia. I'm talking about the community-acquired infection, which we see in our OPD patients. So what are the common organisms which we see in these patients? The commonest bacterial infection is the Streptococcus pneumoniae, and commonest atypical organism is the Mycoplasma pneumoniae. And usually patients are young and they have relatively asymptomatic. And commonest viral infection is influenza A, influenza B. So bacterial pneumonia, the Streptococcus, atypical pneumonia, the Mycoplasma, and influenza A, influenza B is again very, very common. In a specific situation like an alcoholic, Klebsiella is quite common. And COPD patient, influenza, and post-viral Staph aureus is very common. Many times we see the patient presented with the viral pneumonia and after the 10 or 15 days having the cavitation. Initially it is viral infection, now cavitation is because of the Staph infection. In immunocompromised patient, fungal and pneumocystis jirovecii again is very common. How do the clinical presentation of the bacterial, viral and atypical pneumonia differ? Although it is not a gold standard sign, but by taking in a history, we can little bit make a difference. Dr. Puneet, can we take out some point by history that this patient is probably having bacterial pneumonia, this patient is having viral pneumonia?
In bacterial pneumonia, the patient's symptoms look like जैसे develop suddenly high-grade fever, hypotension, maybe confusion. In elderly patient, sometimes patient shows presented with the diarrhea, and there may be a hypotension.
So really it is difficult to differentiate, but there is some point by which we can say that the patient is having the bacterial pneumonia, short history with the high-grade fever. On X-rays, you see the lobar consolidation. In viral pneumonia, the patient is having usually flu-like symptoms and diffuse infiltrates usually confined to the both sides. Where in atypical pneumonia, the patient is having more of the extrapulmonary symptoms, maybe myalgia, disorientation, and hyponatremia is very important sign of atypical pneumonias. So it's very difficult to differentiate clinically, but there is some point by which we can differentiate. Like in case of Legionella pneumonia, it's a healthcare are at risk because this occurs in the hospitals or in the nursing homes. So Legionella disease is a severe form of pneumonia presented with the diarrhea. First symptom is most of the time the diarrhea, confusion, myalgia, no respiratory symptoms. When you do that X-ray, you find that the patient is having consolidation. And this is one pneumonia which is diagnosed by urine test, urine antigen testing, the very, very sensitive test. And prefer antibiotics in this case is macrolide and quinolones. Same with the streptococcus pneumoniae. The commonest organism is this. And most of the patients, they have a lobar consolidation, so dense consolidation on one side. And in case of the Staph aureus, multifocal consolidations with cavitation is the sign of a staph infection. So by these points, we can consider probably that this patient is having this organism. Like in staph, patient is very toxic, multiple cavitation, fast growing disease. And most of the time it is post-viral secondary infection. In case of the Pseudomonas, patient is less toxic, but the sputum production is significant, the greenish sputum, and is having the baseline diseased lung. Maybe bronchiectasis, maybe COPD. And this is a very typical sign of the Pseudomonas, what we call as ecthyma gangrenosum. If it is present, and by seeing this sign in a patient of pneumonia, we can say this patient having probably in a case of the Pseudomonas. Wherein the viral infection, the symptoms are is more of the systematic, bilateral diffuse infiltration of the lung, and it started with the myalgia and upper respiratory tract infection, where in case of the fungal pneumonia, immunocompromised patient, uncontrolled diabetes, malnutrition, alcohol, or advanced COPD, long course of the steroid presented with the cavitation with less toxicity. This seems to be in a case of fungal pneumonia. And these are the two very important signs by which we can say that this patient is having fungal pneumonia. One is what we call as halo sign, and second is reverse halo sign. Halo sign is suggestive of invasive aspergillosis, where the reverse halo sign is in favor of mucormycosis. This occurs in patients who are immunocompromised post-cancer, post-chemotherapy patients. Again, in HIV patients, most of the patients, they present with high respiratory rate, hypoxia, respiratory failure, minimum respiratory sign. When you do the CT scan, you find bilateral diffuse ground glass opacity that's suggestive a patient is suffering with a pneumocystis carinii pneumonia. So, Dr. Rakesh, can radiological presentation help in differentiation of organism? Although it is never very pathognomonic sign.
Yes.
Like in a clinical sign, radiology can help at that point, because most of the patients coming to you with the CT scan or X-ray.
Yes, sir. Actually, CT help us much more in some suggestion which type of organism can be the causative etiology. Like that, if there is the lobar consolidation, this looks it's more suggestive of like bacterial infection like streptococcus or and all these things. If the cavitatory there is the multiple cavitation, bilateral, more favor in the Klebsiella like or staphylococcus. And if there is ground glassing, bilateral, both sides, it's more favor in the viral side. Viral pneumonia can be there. Like that, as you said, that HIV patient who having infection of pneumocystis, there is the presentation like that. Acute patient will present with the acute respiratory failure with the bilateral diffuse ground glassing with sparing of the periphery. So like that, there may be some suggestion we can be help with
Right.
the CT scan.
So unilateral disease with lobar consolidation more in favor of the bacterial infection. If there is cavitation, again in favor of bacterial infection and fungal infection. Presence of cavity is a point against the viral infection. There is no cavitation in the viral infection. If there is cavitation, means the patient is having the secondary infection. In viral pneumonia, most of the time the lesion is bilateral. So these are the suggestive points which you can help you for making the differential diagnosis. CT scan done in our patient. So Dr. Ravi, what are your take on this CT scan?
As we can see in left, generally in this CT there is homogeneous or non-homogeneous opacity on the left side, and as there are no cavitations and it's favoring simple bacterial infection, ground glassing
So the disease
it's
is
viral because
yes.
ground glassing and in viral generally we get interstitial type of signs.
So disease is basically confined to the one side of the lung, left side. You see the different type of lesion. There is no significant effusion. The dense consolidation in the upper part. There is a ground glass opacity and the crazy webbing patterns. That's suggestive of the unilateral dense consolidation, bacterial disease. Look like in bacterial disease. So a CT is not always indicated in these patients. Whenever your diagnosis is not satisfactory and your response to the treatment is not very satisfactory, we should go for the CT scan, because by CT scans we are able to see more lung parenchyma. That will give the more anatomical lesions, morphology of the lesion, which we can confirm the patient in the lobar consolidation if there is encystment of effusion or empyema is not there. So CT scan is not indicated in all patients, but in a difficult patient or your patient is deteriorated, then CT scan should be done. So after 48 hours, the patient starts deteriorating in indoor after starting the antibiotics. The demand of oxygen increased to significantly high. Initially it was 90%, now it is 85%. At room air is tachypneic. Lesion has increased on both sides. So what you will do, Dr. Ashish Shukla? Now the lesion become bilateral, you see in a CT scan, and your patient starts deteriorating even after starting the good antibiotics. So what you will do? You will start non-invasive ventilation with oxygen in the ward, or you will put your patient of HFNC in the ward, or you will ship the patient to the intensive care unit. What will your decision?
Sir, clearly patients has shown the signs of deterioration both clinically and radiologically. Oxygen requirement is significantly high. I would shift this patient immediately to the intensive care unit. And I would start discussion with the family about the potential risk of intubation, and simultaneously we can give a short trial of NIV or HFNC. And if the patient don't show the signs of improvement, then I would consider this patient for intubation and invasive mechanical ventilation.
Right decision. We have shifted this patient to intensive care unit. Now, one more again, the very, very important question. Should I start steroid in this patient or not? What are the guidelines at this moment to start the steroid in patient of pneumonia who is deteriorating?
Just sir, can you show me the last slide? I just need to see the oxygen requirement.
85% at room air, but it is significantly low for this patient. So we have shifted this patient to the ICU now.
Sir.
So will you start steroid in this patient or not? He is already on antibiotics.
Can be started on the IV antibiotics, sir, because there is the refractory leading to the ARDS. So some consideration of IV steroid may help with, but looking up the previously looking up the CBC and PCD count. So we have to previously, before adding the IV steroid, we have to look again what is the status of the inflammatory markers or the
Okay. So this subject of whether steroids should be used or not is still debatable. With a lot of studies says may or may not be. Like the ramp cap study says there is no advantage of using the steroid in this patient, whether it is solumedrol or methylprednisolone. Methylprednisolone, this study says, this is escape study of steroid in pneumonia. They say there is no change in the outcome after adding the methylprednisolone. But this is one study, the CAPCOD study, say that using the corticosteroid, 200 milligrams, for first 4-5 days in a patient who requiring respiratory supports, they have the better outcome. So there is still controversy, but this is the consensus. If your patient is deteriorating on antibiotics, demand of oxygen increasing, so this is the times when we can use steroid if there is no absolute contraindications. So next question again to you. So what you will prefer, whether it is NIV support or HFNC, or you will intubate the patient?
So there is a protocol of, first of all, we will see in an increasing pattern. We will increase the oxygen first with low flow devices like simple these nasal cannulas and oxygen mask. Then if our flow is increased, first of all, in pneumonia, I will not go with NIV. I will go, if demand is increasing non-rebreather mask, then I will prefer HFNC only, because I have to see what is the purpose. I have to give oxygenation and not to focus on ventilation. Right. That is
right. So this patient is basically having the more of the oxygen demand, hypoxic failure. If you put the patient on NIV support, is already tachypneic, that the patient will not tolerate. And literature is also conflicting that putting this patient on NIV support is not a good option. It's better to go for the HFNC, what we did in this patient. We put this patient of HFNC because primarily there is a consolidation which work like in a shunt. The demand of oxygen is very high. So HFNC is the better option. NIV is not a good option for these patients. So because of shortage of time, I'm running fast. On the 5th day, the patient further deteriorates. Bilateral lesions has increased. The demand of oxygen also increased. And what you will do, Dr. Rakesh? On HFNC, the demand is increasing. Patient become more hypertension. What is your diagnosis at this time?
Actually, as from starting, we are looking that there is the clinical radial deterioration in this patient. Patient is not improving even on the upgrading the antibiotics. Even we have increased the oxygen support. Even the failure of the HFNC. So there is the right time to keep the patient on the mechanical ventilation, because there is the inflammatory surge increasing, ARDS pattern is increasing, lung injury is increasing. So definitely it's a time to intubate patient to give the proper oxygenation and reduce the work of breathing, so that we have a time to reduce the lung injury or infection.
Absolutely agree. Now the patient has bilateral significant lesion, seems to be in a case of progressive lesion leading to the development of ARDS. If we see the definition of the ARDS, this patient is absolutely fitting into the diagnosis. The timing is within 7 days, chest imaging bilateral infiltrates, origin of edema is not cardiac, and there is significant demand of oxygen. The PF ratio is less than 200. So this patient is having moderate ARDS. So we should not try HFNC further. We should not put the patient of NIV supports. It's better to go for intubation. So patient is intubated. Now we have an opportunity to do the bronchoscopy, because you see the last 3-4 days he was quite tachypneic. He was not producing the sputum. So it's very difficult to make a microbiological diagnosis. Once we put the patient on ventilator for intubation, it was easy to do the bronchoscopy, and bronchoscopy Lavas confirmed that he is suffering with mycoplasma pneumonia. That was confirmed with the biofire. We are fortunate we have the facility of the biofire. We get the reports within 6 hours. So there were no any other organism till date. PCT was again normal. So he was suffering with mycoplasma pneumonia. It started from the one-sided disease. So we have started injectable azithromycin. So atypical pneumonias are basically for the mycoplasma pneumonia and Legionella, maybe chlamydia. So these are not very uncommon, but the diagnosis is really difficult. But whenever we suspect the mycoplasma pneumonia, we should look for these signs. Extrapulmonary symptoms are more, like a bullous laryngitis. Many patients, they have very severe ear pain, and a pneumonia is a very pathognomonic mnemonic sign for mycoplasma pneumonia infection. Some patients, they present with encephalitis and uveitis, iritis, and myocarditis, sometimes bradycardia. Sometimes the skin lesions are also present in elderly patients. So what I mean to say that in patients with the mycoplasma pneumonia, extrapulmonary symptoms are more dominant as compared to the pulmonary symptoms. On the 6th day, 24-hour on ventilation, we put this patient on the lung protective ventilatory strategy, not maintaining saturation 82% with all effort, whatever the possible. And CO2 start gradually rising, means the ventilation, patient is having some hypoventilation, and because of raised PCO2, there is a respiratory acidosis. What will be your next step? Yes, please, experts. Anyone? अब क्या करना है? वेंटिलेटर पे डालने के बाद भी
extracorporeal membrane oxygen.
Want to do anything else before doing this?
Sir, I would consider the prone ventilation, but
Absolutely.
already.
This patient should be put in the prone ventilation, because in first 48 hours, the patient is not improving even with the best effort with the lung protective ventilator strategy. Put the patient in the prone position. And this is the time it should be done, not after the 5 days. In the first 5 days of ARDS, patient should be put on prone ventilation. The prone positioning save life in ARDS when added to the lung protective ventilator study. 70% absolute reduction. I will take 2 minutes more.
Yes.
So patient were kept in the prone position for 16 hours. You see this basic concept of putting the patient in the prone ventilation, that cardiac output increase in the lower part of the lung where it is a good ventilation, and the drainage from the dorsal parts to the trachea and other airways, this lung become more soft and more compliant. That the basic concept of putting the patient on the prone position, most of the patient that recovers. But there's a lot of complication putting the patient in the prone position. Your staff should be very, very trained. If your staff is not trained for putting the patient on prone position, not to do that, because mortality is significantly increased if your staff is not trained. So we repeated this X-ray and CT scan. Can you find out what are the new development in the CT scan? Anyone? Initially, it was one-side disease. It became bilateral. We put the patient on ventilator. Now further deteriorating. See what happened to the CT scan. Yes, there is a development of the pneumomediastinum. Even over the lung protective ventilator study, you see that air is present in the anterior mediastinum. So it is very common complication, and this is a very dangerous situation. Who is in a patient on a positive pressure ventilation with the stiff lung, not maintaining the tidal volume. You cannot increase the PEEP. You cannot increase the FiO2 to more than 50%. Even in the prone position, he is maintaining 84% perfusion. The tracheostomy done. Further deteriorating. The patient is having pneumomediastinum, increased PCO2, respiratory acidosis, high pressure on ventilator because of the stiff lung. You can't give the relaxant for the longer period. The saturation is now 78%. Now what are the options? Withdraw the support or do something more?
Now is the almost all thing has been failure. There is the more complication, pneumomediastinum, refractory, restrictive lung disease leading to fibrosis. So right now the next option should be like ECMO should be initiated as early as possible, because there is oxygen problem, there is CO2 retention, all things is it.
So this is the third week, 25th day of the pneumonia. And there is stiff lung, there is fibrosis. And you can see the status of the lung is completely fibrosed. And we put this patient of the VB ECMO. We will continue. So I'm not going to discuss the indication of VB ECMO. You see the patient, they start gradually recovering with the fibrosis but persisting. And we have been off this patient the 28th day, VB ECMO being off with the high oxygen demands. But there was the significant demand of oxygen even after weaning. And patient family was exhausted, and after 48 hours of bleeding, the patient is having the massive pulmonary embolism and collapse, and they died. So in this situation, before weaning from the ventilator, there is one option that patient should go under lung transplant. And this is the patient, young patient, relatively younger patient, and single organ failure. They are ideal patient for the lung transplant. In this situation, we should take an opinion with transplant unit. And that is the only things which can save the life of these patients. But unfortunately, we lost this patient. I was near about 42 days.
Dr. C.S. Gupta sir, he is senior renowned pediatrician of Prayagraj, and Dr. Rajneesh Rai sir, he is senior pediatrician and neonatologist at Srijan and Vatsalya Hospital, Prayagraj.
with hard work. So if you have any questions, sometimes what happen after doing everything.
So we are running short of
Yes,
time.
sir. So this is my last slide. This was the true
yes.
case which we have presented. It may be some mistake in my management of this patient, but this is learning how we manage these patients. And thank you very much.
Thank you, sir, for the wonderful clinical pearls. I would request Pallavi to proceed.
Thank you so much, sir, for a very insightful discussion on pneumonia. I now request our moderator and the other panelists to kindly get off the stage for the felicitation ceremony. And I would request organizing secretary and secretary AMA, Dr. Ashutosh Gupta, sir, President Dr. J.V. Rai, sir, immediate past President Dr. Kamal Singh, sir, and President-elect Dr. Ashok Mishra, sir, to kindly felicitate the panelists.